Hello, everyone, and welcome to the orthoPAC podcast presented by PAOS. Miles Gilbreath here. I'm the Southeast Regional Director, and I'm joined today by Haven Donovan, one of our 2024 Susan Lindahl Memorial Scholarship winners. Hey, how's it going?
Good. How are you? Thank you so much for having me on the podcast. I appreciate it.
Yeah, absolutely. It was great meeting you in Nashville, and once again, congratulations on receiving the scholarship this year.
Thank you. I honestly can't thank, PAOS enough for the opportunity to just apply for it, let alone be chosen as one of the recipients. It was an amazing experience being in Nashville and getting to present and meet a lot of, future fellow PAs who work in the orthopedic setting. So it was just a wonderful experience. So thank you.
Yeah, that's great. As everyone's about to hear in more depth, you're very well deserving. Tell me a little bit first about your experience in Nashville. What did you get to do? What did you learn?
Nashville was an amazing experience. My school was very gracious enough to let me miss a few days of my first clinical rotation to go, and it was very, very much appreciated. I got to sit in on some amazing, amazing lectures. The speakers that they had, ranged from all different, backgrounds, whether they were PACs, ATCs, MDs, physical therapists. Just getting to sit in and see some clinical application of orthopedic things that I will get to see in the future as a hopefully orthopedic PA. Also, just getting to kind of network and meet other people who are transitioning from an athletic trainer to a PA, have been PAs, their whole career. It was an awesome opportunity to just meet and greet other people. I also got to do one of the breakout sessions, do a little clinical application of cast. So it was really cool to also have that hands-on experience of some things that I'll get to do in the future.
Yeah, that's awesome. I know casting and splinting in PA school is at least for us, it was a half-day workshop. So always more experience with that is great. And I completely agree with you. I think the networking component is one of my favorite things of conference every year.
Absolutely. And I will say they also had an awesome breakout session for new PAs who were in the clinical setting for less than 5 years, and getting to hear their experience was also invaluable. I have to say that was really great, especially from a student perspective.
I know you mentioned clinical rotations. Where are you now?
Currently, I'm on my fourth clinical rotation of 9, and I am in an urgent care setting right now. So it counts as our family med urgent care.
Are you going to get to do any orthopedic rotations?
Yeah, so I'm very excited that my school allows us to choose a clinical rotation of our choice, and that would be my 9th rotation, my last one. And I've chosen orthopedic, and I've actually decided to do a mix of pediatric orthopedics, hopefully some trauma orthopedics, and some joint replacement as well. So they'll mix a little bit into that 5 weeks for me.
Now, where will you be doing that rotation?
I'll be at St. Luke's, which is in Pennsylvania, and they're on the border of PA and New Jersey.
That sounds great.
Yeah.
So I know your background. You were an ATC. You had both on the field and clinical experience. Tell me a little bit more about what you did before you went to PA school.
I graduated as an athletic trainer back in 2017, and I did 2 years of high school experience as an ATC, working through a hospital network. An opportunity opened up to be working in our clinic. And so then I transitioned to a physician extender, and I have done 4 years of physician extender between 2 different hospitals. And that experience was invaluable because I got to do some more hands-on clinic-based work. And I really got to see the physician assistant role in that setting as well, which really compelled me to kind of further my education and go back for PA.
Yeah, what you didn't mention there is that your clinical experience was at HSS in New York, and you still have close ties there. So that's awesome pre PA experience.
Yeah, I will say being at HSS was probably the best decision I ever made, as far as I actually put off PA school for a few years in order to work there just to get some more clinical experience, especially during the pandemic. And it was the best decision I ever made. Working with some of the best physicians in the orthopedic community, it was invaluable. Just the technology that they have access to, and not even just from an MD level, even like the PAs and the PTs and our x-ray techs were awesome teachers while I was there. So I got to do a lot of hands-on with ultrasound guided injections and really see some new emerging technology as far as treatment. So it was an amazing experience working there.
Yeah, it sounds amazing. I also delayed about a cycle just because of where I was living. I think that if I was at HSS, I probably would have put it off for the orthopedics as well.
Yeah, no, I'm very grateful I did, and again, I still have ties there, which is awesome, and it is my hope and goal to apply there once I'm done and hopefully rejoin my HSS family.
Let's pivot a little bit and let's talk about your clinical pearl. You wrote a great synopsis of Lisfranc injuries. Tell me why you picked that.
Yeah, so I had a couple reasons why I chose the Lisfranc injury. First and foremost, when I was an athletic training student, I actually got to see like firsthand, post-operatively, a patient returning from this injury. And in school, I feel like it's really hit home. Like, never miss this. Like, if you suspect this, you need to get them, urgent care. Like, they need to have this addressed. And so, seeing it from a student athlete that was coming off of surgery in that transition from rehab back into play, it was really interesting to see her journey and hear her experiences. And then while in school, both as an ATC and in PA school now, Lisfranc injuries are something, again, that we're taught, don't ever miss this. This is something that can really be debilitating down the road. So for me, I always said to myself, yes, we're told not to miss this, but what are some things that we can really fall back on in our clinical practice to say, yeah, I've definitely ruled this out and I've done everything I could to make sure my patient doesn't have this. So that's why I kind of went to the research and wanted to find some clinical pearls that, we can apply to our everyday setting to make sure that we're mitigating the misdiagnosis of Lisfranc.
Talk me very briefly through the anatomy of the Lisfranc complex and the injuries for our listeners.
As far as the anatomy of the Lisfranc, it consists of that first through the fifth metatarsal, and then the cuneiforms, the first, second, third, and that cuboid. A lot of people just think of it, oh, we just pay attention to that second metatarsal as well as, that middle and that first cuneiform, but it actually does comprise of that entire joint. As far as mechanism and things to kind of be mindful of, it's, you typically see this individuals who fall, individuals who have, falling in school. We're always taught like, oh, somebody who falls off of a height. But also being mindful that there's also the low energy impact as well. So individuals who kind of have their foot in that plantar flex position and apply that axial load with rotation. So you think of, your rugby players, your soccer players who pivot and turn, who apply that force, and you can also see that injury as well.
Yeah, I think you hit the nail on the head there with the plantar flexed axial load. That's kind of the history that I perk up a bit when I hear that type of mechanism for Lisfranc. It's always a part of every midfoot differential, and it has to be manipulated and ruled out in some way. But transitioning more now to the physical exam, what findings are you going to see in the Lisfranc injury patient?
Yeah, so I think from like a clinical pearl setting, we automatically think from a physical exam, your palpation is key. Like, am I having tenderness in that metatarsal where the cuneiforms meet? Am I having tenderness there? Is the patient non-weight bearing versus weight bearing? There's some things that we need to kind of, tease out. So I think from just inspection wise, you'll see some for individuals who have like a pretty obvious deformity or somebody who comes in with bruising and swelling, you're automatically going to start thinking that. But oftentimes there are individuals who have those subtle Lisfranc injuries where you're not going to see a lot of bruising, you're not going to see a lot of swelling. So again, that's where our palpation comes in. Palpating that area, are they tender through that Lisfranc joint? We start to perk up. The non-weight bearing versus weight bearing, I think that's a really big thing to be mindful of. Most often, your Lisfranc injuries are not going to be individuals who weight bear, but there are individuals, who can muster through pain and do present with weight bearing on presentation. So when those individuals are there, there are some things that we can do to kind of tease that out. One of the things that I had found during my research was doing what they called like a toe rise test, but really it's just a heel raise. So when you suspect this patient has tenderness through that Lisfranc joint, but they're weight bearing, am I thinking they actually might have a Lisfranc? There is something we can do on physical exam. So having that individual do the heel rise test will oftentimes elicit not only pain, but the patient also might feel some instability as they kind of go through that joint if that ligament has been torn. So that's just another clinical pearl to kind of keep in your toolbox when you are kind of evaluating for Lisfranc and trying to rule in versus rule out.
Yeah, definitely. I think, one thing we had talked about was that single leg raise test. I also use that for PTT tendonitis. And so that's where the physical exam with the history and the palpation all kind of comes in to give you that big picture. One thing I found interesting when I was reading through your presentation and your source articles was that, I got a little refresher. That Lisfranc complex comprises all of the TMT joints. And when I see presentation that's in, say, third through fifth TMTs, I'm a lot less concerned than I am when it's the first and second TMT joints. And so that was a good thing for me to remember that, okay, yeah, those lateral midfoot injuries, those also affect that Lisfranc complex.
Absolutely. And I will say I was in the same boat until I did my research project as well. Just because in school, again, we're taught that Lisfranc ligament really just runs through that complex where the second met is. It's important not to rule out when an individual does have more lateral pain. You still have to be mindful that ligament and that complex could still be affected.
Yeah, that's awesome. Talk me through a little bit the imaging concerns. You made some great points about urgent care type images. What should we be getting and what should we be looking for?
Yeah, so I think that's probably one of my biggest, this of the three, I think the radiographic imaging is probably the biggest pearl that I think we as clinicians kind of falter on. And I think from like an urgent care setting, when you're in that setting, there are some presets that you automatically get. Oh, okay, someone's coming in with right ankle pain or right foot pain. Okay, we'll just get the right ankle. There's really not much specifics as far as, well, is it weight bearing versus non weight bearing? We kind of have these preset views in those urgent care and ER settings. I think that's why it's really important to obtain a good history, a good physical exam before we even start to do the radiographic imaging. Because for individuals who might have that subtle Lisfranc injury, they require a more specific radiographic imaging. So, really, to tease out and really to compare bilaterally, you should be obtaining bilateral weight bearing views of that foot. That kind of helps to better differentiate that very subtle, it's really only needs a 2 millimeter of misalignment to kind of classify as a Lisfranc. And that's very hard to see if you only obtain one view. So obtaining that bilateral view helps you to compare bilaterally. When we do the non-weight bearing, we're not putting stress through that joint. So obtaining the weight bearing really helps to kind of put more pressure through that joint and helps to widen that gap to better visualize.
Completely agree. Weight bearing images are paramount to the practice of orthopedics, and comparison images are also just as important. So, anytime I do a foot series, I at least get a bilateral AP. Same thing with my knees, same thing with my ankles. So basically, my rad techs know that anytime the person's standing there getting an AP image, just shoot both of them. They're already in
Absolutely.
position. Just get both of them. And then if I have any further doubt, I can send them back for additional comparison views if I need them.
Absolutely. And I feel like in the orthopedic world, we are educated a little bit better on the bilateral weight bearing views. Because even in the urgent care setting that I've been in, when I ask that question, a lot of the PAs or the doctors, it's not even something in the back of their mind to check like a weight bearing view. They're very set on, okay, well, let's make sure there's no fracture. But there's a lot of other components that we can obtain from those weight bearing views, which make them, I think, invaluable.
I think you've covered Lisfranc injuries very well in depth. What we talked a little bit about this previously. What are you looking at doing once you get out of school?
I'm definitely very interested in returning to orthopedics, hopefully, again, back at HSS. I'm very fortunate that HSS has just opened or a larger branch in New Jersey, which is where I'm from. And they actually just started in their New Jersey, kind of piggybacking off their Manhattan office. It's called Ortho Now, which is basically an orthopedic only urgent care. And having had the urgent care experience I have now, I really like that clinical setting of, some those urgent emergent cases that kind of come through, especially just for orthopedics. So I'm definitely interested in returning to that if it's available upon my graduating.
I'm an orthopedic urgent care provider. I think it's a paradigm that's spreading rapidly throughout the field. I helped start it for my practice back in 2019. We branded it as Urgent Ortho, and I love it. I mean, every day is different. I never know what I'm going to walk into. It's just it really suits me. And from what I know about you, I think you would excel in that field as well. I would give you a couple bits of advice is one, make sure you have a close relationship with the physicians that are going to be overseeing the clinic, especially if you decide to do it as a new provider, which can be difficult. I know you have a great orthopedic background, but it was still difficult. That I was still learning new stuff every day, every week. I'm still learning new stuff, and just making sure you have that support. Another thing that I know I'd mentioned to you in the past is, making sure that you have the respect as a provider. And it can be difficult to go back to a facility that you have worked in a clinical staff role as a provider, just because they knew you as an ATC. And so sometimes it's hard for people to shift the way that they see you. I think having this being a new location, separate from the old office, maybe completely new clinical staff, completely new physicians would be really a really good way to mitigate that downfall.
No, that's honestly amazing advice. Yeah, I think that it's definitely a new and emerging setting, but being mindful, like having that support, especially as a new grad, I will say I think that is something that sometimes does make me a little nervous. Being in clinicals, I have my preceptor to fall back on for further questions, but you know. After August, I will be the clinician and I will be the one making those decisions. So I think having a good support system in that setting is very vital, especially as a new grad. So I think that's awesome advice. Thank you.
Yeah, no problem. Hey, Haven, it's been great chatting with you. It's been great getting to know you. I've been thoroughly impressed every interaction we have, and I have no doubt that you're going to be a great PA. And if the field is so lucky, a great orthopedic PA. And I look forward to seeing you around PAOS for years to come.
Thank you again so much for this opportunity. I really appreciate it. Again, PAOS has been an amazing resource to me and getting to interact with other PAs in this setting. It really makes me look forward to my future, hopefully as a PA in the orthopedic setting. So thank you.
I completely agree with you. I mirror the sentiment to the organization, and we appreciate it. And PAs like you, PA students like you, are the reason that we do this scholarship. So thank you a lot.
Thank you.
Thanks everyone for joining us today. I hope y'all enjoyed that as much as I did. A quick reminder for current PA students or any current PA students you may know out there, the 2025 Susan Lindahl Memorial Scholarship application is open. Visit paos.org/scholarship for more information. We are excited to announce that we're going to be giving out 4 $5,000 scholarships this year to prospective orthopedic PAs who are currently students.